Yeah, I mean, I agree with Nigel. So the there was a lot of hope for the normothermic machine perfusion, but then following the following two trials, and mainly the multicentral trial, essentially what the study showed that compared to the conventional cold storage, the only difference is you have some uh, viability parameters that will encourage surgeons to use or not use the marginal grafts or any kind of grafts. So the difference between the study group, which is with non-metallic machine perfusion, and the control group, is in the study group you had more usage of these organs compared to the control group, where the discard was higher. But then in terms of graft dysfunction and in terms of survival, there was no difference. And that's why we are not, I mean, at the moment we are in dilemma. We think the advantage will come maybe in the near future with machine perfusion, with the normothermic machine perfusion, and some therapy, some interventional work during the perfusion of the organ, either by stem cells or by different therapeutic intervention. But at the moment, as we stand, cold storage remains the gold standard. And to go back to the difference between the normothermic and the hypothermic, I think both of them are valid and they're still growing, but the principle behind the two techniques is different. Actually, is different. What you see in normothermic machine perfusion is when you place the organ on the device, you actually reperfuse the organ on the device, and all of the syndrome that Nigel mentioned before, the post-perfusion syndrome, that will go. You don't see it because it's on the device. So if you have some cytokines responsible for this kind of symptoms that the patient experience following the perfusion, that will go because they will be washed out with the machine. So that's why you don't see much of post-perfusion syndrome. But then if the organ is not working, you will see it a little later, after 1 or 2 days.
Thank you. Thank you. I'm just going to go through the questions from the chat, Prof. First question is by Dr. Gautam Krishna. Post-transplant hyperglycemia, can that be used as a way to monitor graft function after transplantation? Prof, you're having your...
You have to unmute, Prof.
Sorry. Not really early on, because sometimes when livers have an ischemic hit, they become insulin resistant. And so actually there's often a need for insulin early on. And I don't think it necessarily reflects how that liver is going to work in the longer term. So no, it was always said in the older literature, the patients who needed insulin, you need to be wary about. But actually, I find it quite reassuring if the patient's on a little bit of insulin, providing the lactate's coming down within that scenario. So no, I'm not too worried about that.
Thank you. Thank you. The next question is by Dr. Ashwant Kumar. He wants to know what is your approach to early portal vein thrombosis? Would you go ahead and do a surgical thrombectomy, or would you consider thrombolysis?
Oh, look, I think if you get early portal vein thrombosis in any scenario, be it living donor or cadaveric, you go back in. There's a problem there. That problem may be technical, the length of the portal vein, some stenosis, but it's more likely to be inflow problems, and it's going to be related to shunting. So almost always, if you get early portal vein thrombosis, there's a technical problem. It needs to be sorted as soon as possible. Do a CT scan, identify what the issues are, and go in. Nowadays, our radiologists are so good with intervention. They can stent narrowed portal veins. They can open things up. They can even go through the liver and through the portal vein and close off collateral circulations. But if it's happening in the first few days after surgery, the surgeon needs to sort things out.
Thank you. There's one question I think that was asked previously. If Dr. Abid Sudhil can answer that. You know, we were talking about early allograft dysfunction, and one of the participants asked whether is there any particular etiology that you would associate with a higher risk of EAD. You know, we talked about MELD and things like that, but is there any particular disease where you would think that these patients are more likely to behave badly after transplantation?
I suppose there are various aspects to think about. Your patient with decompensated alcohol-related cirrhosis may be a very different patient than your younger patient with portal hypertension and autoimmune hepatitis. So the phenotype of the patient, their immunogenicity, their likelihood of becoming septic, their likelihood of developing rejection at day 5 to 7, much more likely in the younger patient with a strong immune system than your alcohol-related liver disease who's decompensated, sarcopenic, large volume ascites. So I think it's just individualizing each particular patient, individualizing what you think the risks are going to be in the first week and subsequent weeks, understanding what your aims are every time you see the patient, rather than thinking about particular ET. I just say individualize it from patient to patient.
Thank you. Thank you. I think it's another question by Dr. Raghavendra. You know, post-transplant, when we see a patient is having an elevated bilirubin, can it be just due to hemolysis? If everything else is going well, would you be happy with that, or would you consider hemolysis as also a part of early allograft dysfunction?
I mean, if it's predominantly unconjugated, you look obviously into the reasons for a predominantly unconjugated hyperbilirubinemia, and that may be hemolysis. Of course, the earliest form of graft versus host disease with the ABO compatible mismatches often presents with that hemolysis syndrome at about day 7 post-transplant, with the elevation in bilirubin and mild elevation in transaminases.
Thank you.
Yeah, so if I can, I mean, always do a split. You know, if you've got a high bilirubin, always do a split. Obviously, there are some conditions like Wilson's disease where you may see hemolysis post-transplant. So being aware of that and always looking to see what the degree of conjugation is. And as Abid says, and I think it's particularly important for living donor liver transplantation, where the incidence of graft versus host disease is much more common than after cadaveric transplantation, with an incidence of more, you know, of at least 1 in 700. And if you're dealing with living donation between cousins, it may be more common than 1 in 100 cases will get significant graft dysfunction. But we see it in the cadaveric world after ABO compatible. So for example, blood group O into A, and it's always around day 10. These patients get quite ill, they look septic, they suddenly hemolyze, the bilirubin jumps, and if you're not aware of the condition, you then give blood and you feed the hemolysis. So you need to understand what's going on, recognize it, and you give
donor-specific blood.
The donor-specific blood, so blood group O blood. So that's a good question, and Abid's made a good point.
Thank you. Thank you. There is one question by Dr. Sala. Can we unmute him? Is it possible, or?
Dr. Sala.
Yeah, he's raised his hand. I don't know how to do that.
Moa, can you unmute? Moa, can you unmute Dr. Sala, please?
Hi. Hello?
Yeah.
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 Hello.
Hi.
Yeah, Dr. Reddy, thank you very much for the invitation. My question is
You need
for
to put
Professor
your camera
Heaton.
on.
It's on actually, is it?
Oh, no.
Yeah.
Yeah, what's the question?
Yeah, the question is for Professor Heaton. I think early graft dysfunction, as you said, that we have to rule out technical issues at first, like inflow and outflow issues. But actually, they mentioned about closing the abdomen in a large liver, because when I was in training in Vancouver, we have actually 2 cases with early graft dysfunction. We then figured out that we closed the abdomen in a large liver. So what we did, we take the patient back, then we open the patient, then we use a biological mesh to that, then the graft is improved. So I think maybe you may mention it, if that like a wrong packing of the liver that may make the liver congested, and the graft will be dysfunction after that. So in your experience, how often you face this kind of cases?
Yes. So again, you make a good point. Actually, that was something I'd thought about in preparing the talk, and then I forgot to include it. Recognizing when you put a large liver in and it gets compressed, and trying to close the abdomen is important, and particularly if you've been transplanting for acute liver failure or a difficult retransplant where the gut is edematous, where and maybe you're dealing with a small abdomen in a small person, you can get a compartment syndrome. So we have a very low threshold for leaving the abdomen open and just putting a mesh over it. If there's any doubt about it, or if the patient's gone back to the intensive care, then either measuring the intravesical pressure or the femoral venous pressure and looking for a gradient. And if you've got a pressure of 25 millimeters of mercury, take the patient back to theatre immediately, open the abdomen, get rid of that, because otherwise you'll be contributing not just to liver dysfunction, but also prolonged renal dysfunction. And I've even seen multiple bowel perforations as a consequence of a prolonged intracompartment syndrome. So yeah, that's a very good point. Thank you.
Thank you, Prof. Thank you. I think we'll move on to the next session. We're already running a little late. I think Dr. Rajni and Silva, can you start off the next session and hand over to Professor Heat?